So we're going to spend a few minutes now talking about knee replacements and knee osteoarthritis. I have a few models here to go through as well as some x-rays to help you. This is a knee model that shows actually a partial knee replacement or a couple of options, but it basically gives you what the knee looks like internally. So the knee joint has two different types of cartilage that we often refer to. So there's the smooth white cartilage on the end of the thigh bone and on top of the shin bone. That's called hyaline cartilage, and that's the normal cartilage that breaks down as you age and develop arthritis. Inside this knee, if I hold this kneecap out of the way, you can see there are also these triangular shaped, C-shaped cartilages on the inside and the outside. That's your meniscus. So you have an outside and an inside meniscus, so medial and lateral meniscus, and those are different types of cartilage, and they act as shock absorbers between the hyaline cartilage on the outside and the inside of the knee. As you age, you start to wear out the cartilage. So this model actually depicts some rough-looking cartilage and in the center of the knee. But basically what I wanted to show you with this model is, as knee surgeons, we will often divide the knee up into three compartments. So inside or medial, outside, and lateral. And there's a third compartment that's created behind your kneecap and where it articulates or runs in the groove on your femur. So as you bend and sit in a chair and flex and extend your knee going up and down stairs, there's a patellofemoral compartment, which is basically the back of your kneecap or your patella and where it contacts the femur, which is called the trochlear groove. So when we assess people with knee pain and knee problems as they age and develop arthritis, we can see different patterns of wear and tear. Some people can wear out just one compartment of their knee, like the inside, and in this case they might get a partial knee where we only resurface the inside portion of their knee. And this is really something that's determined on a patient-by-patient basis. If you start to wear out two or more of your compartments, then you ultimately need a total knee replacement, and that's what we're going to be talking about here for the next few minutes. So when we do total knee replacements, how do we take you from having a painful, stiff knee like this one to a good functioning total knee replacement, and what does a total knee replacement look like? Well, first you need to understand what it looks like on the x-ray here. And I have an illustrative x-ray brought up here of a patient who has arthritis in both knees. This is the pre-op x-ray here showing that on this side, both sides, the patient has fairly significant knee arthritis. And they've already had one knee replaced. So this is an x-ray showing what the knee replacement looks like on x-ray. You can see there's metal and metal attached to the bone, and in between, what you can't see is there's plastic, and the plastic doesn't show up on x-ray. In addition, on the back of the kneecap, we put a plastic button. So this is what it looks like in real life. So this is an exact model of what a knee replacement looks like, and I'll take these parts off so I can show you what we have to do. I often tell patients that we're like finishing carpenters when we do these knee replacements because there's lots of bony cuts. But this is basically a model of a knee. This is a femur, so this is the end of the thigh bone. This is the shin bone or the tibia, and where those two meet is what creates your knee joint. So effectively what we do in knee replacement is we cut out the center portion of your knee and we put in a new joint surface. So I often tell people we are like carpenters, and it's like having tires on your car. You can buy the best tires in the world and put them on your car. If they're not balanced and aligned very well, they won't work very well and they won't last very long. So what happens from a technical basic standpoint is we go in, we remove bone from the end of the femur, and there's all these specialized cuts and angles and things we look at in terms of rotation and angles. We finish cutting the femur, and then there's multiple different sizes of the femoral component. And that basically fits like a glove, and that goes on and it becomes metal and resurfaces the end of the femur. There's then a cut on the top of the shin bone or the tibia. Then there's a metal piece that goes on there. Now these two metal pieces are fixed to the bone with cement. So there's actually a cement or a glue, it's like epoxy, and we actually put that epoxy on the end of the bone, and then when the final implants go in, we push the implants onto the cement, and after about 14 minutes that hardens, and then it fixes it to the bone. The last part of the equation is this plastic bearing surface. Now that plastic bearing surface comes in different sizes, literally in 1 millimeter increments. So it could be 10, 11, 12, 13 millimeters thick. As a surgeon, after we put the new knee in, we check the ligaments and we test to see how tight or loose it is. And what happens in our knee replacements is these black elastic bands represent the medial and lateral collateral ligaments. Those ligaments stay intact and they help tension the knee and keep the knee stable. In the center of the knee, you have your anterior cruciate and posterior cruciate ligaments. And those ligaments in a normal knee that's not replaced are in the center of the knee and they cross in the center. And those ligaments basically stop the knee from going forward and back. In knee replacements, in this particular type that we do, we actually cut those ligaments out of the center. So you don't need those ligaments because we replace those ligaments with the shape of the prosthesis. So what you can see here is the shape of this prosthesis is like a ball in a socket. So that ball and socket joint here on the middle side, on the medial side, engages the shape of what's called a sphere knee. So this gives the knee joint stability. It prevents the knee from dislocating front to back. The other thing that this type of particular design does, and there's a whole other section that we'll go into on a video that talks about knee design principles. But in essence, what happens is this allows the knee to bend and extend, flex and extend, and rotate during flexion. So it's a more natural biomechanical phenomenon that occurs in this artificial knee. And what holds that in place are the collateral ligaments, which remain intact, and we'll come back to that in a different section. So now, if the end result for us is to put in a knee replacement, and we have to make all the bony cuts, how do we achieve that? Well, historically, what's happened over the years is surgeons would use different types of guides on the bone. They'd put rods up and rods down, and they'd look at the alignment of the leg and try and make the bony cuts based on the patient's limb alignment and anatomy. Over the last 10 years or so, we've had some additional breakthroughs in technology where computers have come into the operating room. We've used navigation and computers in the operating room to try and improve our accuracy. The reason for doing that is if you think about it as a carpenter, as an orthopedic surgeon doing knees, my eye is only so good. I can't appreciate a few degrees of angular deformity or a ½ millimeter of bone resection. So we know that bringing computers and robots into the operating room increases our accuracy. The trouble is when we started using computers and robots in the operating room back in 2005, it also made us less efficient. So we'd have to drill pins into the different bony prominences. We'd have to basically tell the computer where the limb was in space. So we'd have to touch different parts of the knee and register the center of the hip and the center of the ankle because the computer doesn't know where your limb or your knee is in space. So we have to build or create a model for that robot or computer so it tells us where to cut. So we tried to figure out a better way to do that. So in 2008, we came up with a system that my partner and I and some other surgeons developed, and it's called MyKnee. Effectively what it is instead of collecting all those points in the operating room and building a picture for the robot or the computer, we use a CT scan ahead of time, preoperatively. We do a CT scan from the hip all the way down to the ankle, and we build a three-dimensional model of that patient's entire limb. What happens in that instance is we literally recreate what the limb looks like, so there's no guesswork. We're literally taking the image of your body, and we're using that image to create the perfect size, position, and location for the knee replacement. So how does that work in reality? After the CT scan is done, we ship the images over to Switzerland, to our engineers in Switzerland, and then they will send us a plan. What happens is once I pick the final plan for the knee and approve it, and we'll come back to how I pick which plan for which patient in a minute, but effectively what happens is they use the technology to create this system and they send it to the operating room. So there's two plastic blocks. There's a model of the end of the femur and there is a cutting block. So I tell people this is printed out on a 3D printer. There's a code on here that identifies the patient and the surgeon. So there's only one of these for one patient in the world and one surgeon. This is how it works. This is like a custom carpenter's miter box. So what happens is when I pick the final plan, size, and position for your knee, they print this out on a 3D printer. Now there's one of these for the end of the thigh bone and there's one of these for the top of the tibia or the shin bone. And what happens is we called the system MyKnee, and I don't know if you can see that, but it says MyKnee on there, and there's all these different codes on it, so there's no mix-up on which patient it is. Once I pick the final spot for your knee, they ship this to us. It comes to the operating room. It's sterilized. We take it into the operative field, and then literally what happens is there's little etchings on this, and I can show you here with the pen. there's some etchings on the 3D model. So these are printed out on a 3D printer. There's etchings that show the surgeon the contact point for the cutting guide. There's also a line that's been etched in here. So it can show the surgeon before he cuts the bone the exact thickness of the cut that we need to achieve. And then what happens is we go into the operating room, we open the knee up through a less invasive approach, we take this and we pin it onto those exact spots. And it fits like a glove because this guide only fits one patient. It's unique, and that's why we called it My Knee. So what happens is we basically pin this into position, and then there's all these various cutting slots and pinholes that sets the position of our jig that finishes all the bone cuts, which ultimately ends up in creating all the cuts here that I showed you on the femoral model. So it takes the guesswork out of it. So we've done this on all of our knees since 2008. It's incredibly accurate, and we can harness that technology and that power to actually do something that's even more unique in the last few years, which is basically try and restore the patient's knee back to where they were before they got arthritis. And that's called kinematic alignment. That takes a little bit more explaining, but the basic premise, which hopefully I've made pretty clear here, is when you do knee replacement surgery, the surgeon cuts off the end of the thigh bone, the top of the shin bone, puts metal and plastic in there, and that gives you the artificial knee. There's two other things I'd like to talk about with respect to knee replacement. One of them is kinematic alignment, and one of them is knee design and how different knee designs can affect how patients do with regards to the surgery. There's a staggering statistic that many people don't realize, but in our literature, in our own orthopedic literature, 25% of patients are not satisfied with their total knee replacement. And we think it has to do with ligament instability, the positioning of the knee, perhaps the knee wasn't put in tight enough or too loose the first time. And so all of these different technologies that we're trying to harness here are trying to reduce that incidence of unhappy patients, and I think we've got that figured out. Here's the way to think about kinematic alignment. This patient is obviously a little bit bow-legged. If we look at the tens of thousands of patients we've seen over the years, and we have a database of all these CT scans from all over the world where we can look at how people are lined up, not everyone's perfectly straight. In fact, most people are a little bit bow-legged, or what's called varus, so their legs actually curve out. Some people are knock-kneed, so their knees actually touch together. Because not everyone is straight, and because some people are knock-kneed and some people are bow-legged, the way to think about kinematic alignment is the historical teaching of how to put these knee replacements in has always been, let's cut everyone straight. Let's cut this tibial cut perpendicular to the axis of the tibia, and let's cut everyone and make them relatively straight. What I explain to my patients in the best terms I can is, if you've been bow-legged your whole life or knock-kneed your whole life and I make you perfectly straight, well, guess what happens? All the ligaments and soft tissues and everything around the knee, it's like forcing a square peg into a round hole. So we end up seeing patients that have trouble with more pain, more difficulty on the surgeon standpoint in terms of getting the knee to balance. So what we have done with this algorithm is, over the last few years, working in conjunction with Dr. Stephen Howell, who's a friend and mentor, we've looked at kinematic alignment, and effectively we're doing all of our knees with kinematic alignment. What does that mean? What it means is that I use this whole system with the CT scan that we just talked about to reverse engineer and figure out where your knee needs to go. Imagine you were 18 years old again and you had no arthritis in your knee. I'm going to make the bone cuts exactly where we think your knee is supposed to be based on your shape. You kind of get a hint of that here. You would look at this and say, in an old-fashioned knee replacement or mechanically aligned, you'd say, well, doctor, you cut that crooked. You can see that the tibia is tilted a little bit into varus. But what our CT scan data showed us is that that's the angle that his joint line wanted to be at based on all of the algorithms and math that we did. So our knees aren't put in perfectly straight. They're put in exactly where the patient needs the knee to be put in. And as a result, in the last couple of years, we've seen patients recover faster, have less pain, have better range of motion and function by sticking with these principles. And I think it's really going to change the way knees are done in the next couple decades.